Today's topic is osteoporosis and menopause. Menopause and osteoporosis both has got a big relationship. All the menopausal females, there are chances of osteoporosis with aging or with a premature menopause be there. So postmenopausal osteoporosis, the basic primary care setting is we should know what is osteoporosis, why should we care, whom to test and whom to treat and how. So this is the definition of osteoporosis. This is a skeletal disorder characterized by it's a compromised bone strength predisposing to an increased risk of fracture. So you can see the difference between the normal and the osteoporotic bones. The bone strength reflects the integration of two main features. First is the bone density and the second is bone quality. So these are few common risk factors of osteoporosis. Number one, most common, that's female. Number two, postmenopausal, family history of osteoporosis, lack of exercises, small body frame, low calcium intake, vitamin D deficiency, smoking, age starting in the mid-30s, but more likely with advancing age. Then the patient is already having the rheumatoid arthritis, hyperthyroidism, hyperparathyroidism, or hypogonadism. Now, if she is taking any medications like corticosteroids, prednisolone, excess thyroid hormones, sometimes for the blood pressure or anything, diuretics, and anticonvulsant, dilantin, phenobarb, and Tigretol. So they can cause more and more chances of osteoporosis. Now, osteoporosis in perspective of the lifetime risk at age of 50. For example, the women at the 12% there are chances of fracture and 50% chances of breast cancer. And men, 17% chances of osteoporosis and fractures and prostatic cancers, 20%. There is a National Osteoporosis Foundation, which is the guidelines are there. The major clinical recommendation is universal is number one is risk, number two diet, vitamin D, exercise, smoking and monitoring. Diagnosis by BMD, vertebral imaging and causes of secondary osteoporosis. Monitoring by BMD, which is a simpler one, and treatment is initiation criteria, options and durations. Now, who should have the bone density test? That's an important point. Women aged 65 and older and men aged 70 and older. Younger postmenopausal women and men aged 50 to 69 with clinical risk factors. Adults who have fracture after the age of 50. Adults with a condition, for example, rheumatoid arthritis, taking medication, glucocorticoids, associated with low bone mass and bone loss. These are the WHO criteria for the postmenopausal osteoporosis. The T-score compares the individual BMD with the mean value of young adults and express the difference as a standard of deviation score. Normally, that's a T-score is -1 and above. Low bone mass osteopenia between -1 to -2.5. Osteoporosis when it is -2.5 and below. So osteopenia is very common, but we should take care as early as possible. Now, whom to treat? The women more than 65 and more than 70, younger with risk factors, DEXA test, T-score more than -2.5 in the lumbar spine, total hip or a femoral neck, or hip or spine fracture. That's a clinical or radiographic. If it is yes, then candidate for treatment. If DX is scored between -0.1 to 2.5, that's osteopenia, and increased fracture risk, then FRAX should be done, 10Y fracture risk, and it's more than 3% of the hip fracture or more than 20% of major osteoporotic fractures, yes, they are the candidate for the treatment. Now, what are the clinical benefit of FRAX? FRAX is basically a calculations tool, and it is just to find out what is the score. So it is derives 10-year probability of the clinical event from the measurable parameters, international recognized and validated, based on the data of multiple cohort studies, easily accessible on the internet or the DXA software. It helps to identify patients who need treatment. FRAX is a multiple questionnaire over there. That is a WHO fracture risk assessment tool. So there are 9, 11, 12 questions, right from age, sex, weight, height, previous fracture, parent fracture, hip, current smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, alcohol, female neck, BMD, etc. These are the 12 points on which we should find it out, yes or in the form of yes and no, and the score is being calculated. If for the major osteoporotic with BMD, it's a 13, then or the hip fracture is there, the 3. So these are the way for calculating the risk. But the limitation of FRAX is not valid to monitor patients on treatment. Only femoral neck BMD is considered. Risk is yes or no. There is no consideration of dose, fracture, glucocorticoid, smoking or alcohol. Not all risk factors are included and clinical judgment is required. And patients with high FRAX score benefit with medication is unknown. Now, role of a gynecologist. At adolescent and adult age to achieve a peak bone mass, the gynecologist is needed. At perimenopause to prevent osteoporosis in high-risk group, if she is already having rheumatoid arthritis, taking drugs or anything like that, they all should be monitored by a gynecologist. And to treat postmenopausal osteoporosis. At late postmenopause to prevent age-related osteoporosis more than 65, usually it's an orthopedic role. Then the level of management, primary prevention, preconception in utero, childhood nutrition, highest peak bone mass, avoid risk factors, children, adults, and adults. Secondary prevention, prevent first fracture after osteoporosis has set in. Tertiary prevention, after first osteoporotic fracture has occurred, prevent another. Now, Indian scenario, prevalence of the low bone mass, 40 years or the more than 40%, 60 years more than 62%, 65 years more than 80% occurs 10 years earlier. High prevalence of the postmenopausal osteoporosis in Indian women. Calcium intake is basically they have the less than 400 milligram per day. This is ICMR study. Low vitamin D, health professionals, 80%. Low protein, sedentary lifestyle, early age menopause, and attention is needed to tackle to modifiable factors. The recommended dietary allowance for the calcium intake for the Indian women, adult women 600 milligram calcium, pregnancy 1200, lactation 1200, and postmenopausal women 800. Now, why RDA not reached? Indian diet, low consumption of dietary products, dairy products, major source cereal, green vegetables, rich, very poor source, rice is a very poor source. Diets have high oxalates like a spinach. So this is the Indian diet. Phthalates inhibit calcium absorption. High salt contain caffeine, increase calcium excretion. Low protein, decrease urinary calcium excretion. Lactase and the lactose intolerance. Malabsorption syndrome, low vitamin D levels. This is a big list of a calcium-rich diet. And the highest calcium basically is with, that's a 300 with the drumstick leaves. There's a maximum one. And the lowest with fruits. So we should know all the vegetables, drumsticks, radish, methi, broccoli, cabbage, all after 100 grams. These are the calcium contents. And most important is drumstick leaves are there. The calcium absorption efficiency with various salts. At 200 to 300 milligram per premenopausal women, calcium carbonate is the almost 38, and the maximum with the calcium lactate, that's a near 50, and the rest everything is 30 to 38 are there. So calcium sulfate, oxalate, TCP, or calcium citrate malate. So when any combination or any drug medical, these are things are there, but the low with 200 to 300 milligrams, there are the chances of having these things. So total calcium intake from dietary sources, if needed, supplements are used, correct the deficient balance. The intake should exceed more than 800 milligram per day. The risk of cardiovascular events calculi are not observed with a recommendation dose of calcium. Now, Indian Menopause Society guidelines consume 500 to 600 ml of milk curd to build a calcium bank in bones. Support it with lots of vitamin C, fruits, vegetables to favor calcium absorption. Protein should be 1 gram per kg of the body weight. Avoid more than 200 milligram per day of caffeine. Daily salt intake should not exceed more than 5 grams and limit alcohol and avoid tobacco. Vitamin D basically in two forms, vitamin D2 and vitamin D3. D2 is ergocalciferol and vitamin D3 is cholecalciferol. Both cholecalciferol and ergocalciferol are sequentially transformed into 25-hydroxyvitamin D3, 25-hydroxy-cholecalciferol or calcitrol in the liver. So vitamin D deficiency reduces active calcium absorption. It affects the bone metabolism. It increases the PTH secretion. More the PTH secretion, it's induced 1-alpha-hydroxylase activity in kidney, converts the vitamin D to calcitrol that enhances the calcium absorption from the gut. So it's all connected and these are the way it works. Now, vitamin D guidelines management menopause 29-2019 Indian Menopause Society infants. Daily requirement 400 to 1000 international unit. Adults 1 to 18 years 600 to 1000 international unit. Age 19 to 50 1500 to 2000 and same for the age 50 and above. Pregnancy and lactation 600 to 1000 and pregnancy and lactation 90 to 50 years. It's 1500 to 2000. Vitamin D necessary for calcium absorption. As I have shown the algorithm before, choose the supplement of the vitamin D unless obtaining vitamin D from other sources. Follow age group recommendation. Avoid going over daily total 2000 international unit or 50 microgram from food and supplements. It is not necessary to consume calcium and vitamin at the same time to get the benefit of the enhanced calcium absorption. Management and maintenance of vitamin D deficiency, adequate sunlight exposure. For deficiency, cholecalciferol, vitamin D3 tablet or powder, 60,000 international unit once a week for 8 weeks. Maintenance therapy, tablet or powder, 60,000 international unit once or twice a month. There are few things are very important. Lifestyle changes to improve bone health, exercises, resistance, balance, weight bearing, self-movement, avoid falling, balanced diet, calcium and vitamin D, rich foods, sunshine, prevent obesity, avoid smoking, limit alcohol consumption. Exercise prescription, exercise should include aerobic, muscle strengthening and a breathing and a balance. 30 minutes of moderate intensity, physical activity, mostly 5 days a week. Muscle strengthening activity should be included at least 2 days a week, 30 minutes per day for the fitness, reduce the chronic disease, 60 minutes per day to prevention the weight gain. 60 to 90 minutes to avoid regain the weight loss. Avoid spinal flexion, forward or side, spine hyperextension and spine loading, that's a jumping motion. There's a safe and good exercise for the osteoporosis, weight bearing exercises, strength training exercise, stability and balance exercise and flexibility exercise. 10 best yoga poses for the osteoporosis is Shavasana, then Marichayasan, then the Supta, Padanguthasan, then Adho Muktasana, then Vrikshasana by standing, then Trikona Asana, and then Virabhadrasana. Then these are the asanas are very important. Now, approved medication, estrogen has got the very important role. It prevents, it doesn't treat. Then treatment is with aldosterone, alendronate, risendronate. These are the treatment one. And zolendronate, they can treat the osteoporosis because they are glucocorticoid induced. And only for the prevention, we can use the calcium, estrogen, we can use the raloxifene, we can use the ibandronate, we can use the alendronate, risendronate, and we can use the zolendronate. Denosumab is used to treat and These are the glucocorticoid induced. They also prevent also and they also treat also. Estrogen effect on the osteocyte, osteoclast and osteoblast. It's regulate the bone growth. It regulation of the bone remodeling. It decrease the bone resorption. It also maintains the bone formation and it regulation of the osteoclast. So whenever there is a low calcium diet, the calcium deficiency shows bone formation and the estrogen deficiency causes bone loss. So the bone becomes thin, brittle and osteoporotic with a decreased estrogen. So decreased ovarian function and reduced estrogen production are associated with the loss of bone and mineral density. And at the age of 50, risk of osteopenia on osteoporosis, and this is the menopause transition, the chances are having more and more bone density changes are there. So beginning from the menopause transition, reduce the estrogen leads to the decrease of critical bone mass. So International Menopause Society recommends an appropriate assessment of the prevalent fracture, secondary causes of osteoporosis should precede any therapeutic decisions. Lifestyle strategies should be part of any treatment. Choice of pharmacological therapy should be based on the balance of effectiveness, risk and cost. And menopausal hormonal therapy, MHT, is most appropriate therapy for fracture prevention in early menopause. Now, role of MHT in postmenopausal osteoporosis. These are the ACE guidelines of 2020, effective for the prevention of postmenopausal osteoporosis. When prescribing solely for the prevention of postmenopausal osteoporosis, therapy should only be considered for women at significant risk. It should not be given, it should be tailor-made and it should be given properly. Women at significant risk of osteoporosis and when non-estrogen medications are not considered to be appropriate. Another important point for the race guidelines, they also say there is a treatment algorithm, lumbar spine or femoral neck to total hip T-score less than -2.5 or history of fracture, high FRAXA or the fracture probability, evaluate the causes of secondary osteoporosis, correct calcium, vitamin D deficiency and address the cause of osteoporosis, recommend the pharmacologic therapy, educate the lifestyle measures, they should fall prevention, benefits and risk of medications, high risk, no prior fractures, very high risk and a prior fractures. It depends upon the treatment point. So if there is a high risk and no prior fractures, aldronate, denosumab, zendronate, zoledronate or the alternate therapy like ibandroid or aloxifene should be given. Reassess yearly for the response of therapy of fracture risk. Increasing or stable BMD, no fractures. Consider drug holiday after 5 years of oral and 3 years of IV biphosphonate therapy. Resume therapy when the fracture occurs. BMD declines because of LCS BTM rise to pre-treatment values of the patient meets initial treatment criteria. LCS is a least significant change and BTM is a bone turnover marker. If there is a progression of bone loss or recurrent fracture, assess the compliance, re-evaluate the causes of secondary osteoporosis, and a fracture leading to suboptimal response to the therapy. Switch to injectable, anti-resorptive, if an oral agent, switch to abalopartide or a romosozumab or a teriparatide if the injectable anti-resorptive or very high risk of fracture factors leading to suboptimal response. These are for the high risk but no prior fractures. But where there is a very high risk and prior fractures, then again these drugs are very, very important like abalopartide, denosumab, romosozumab, teriparatide, and alternate therapy like aldronate and zendronate. Reassess yearly for the response of therapy and fracture risk. If the patient is giving the denosumab, continue therapy until the patient is no longer high risk and ensure the transition with another anti-resorptive agent. If the patient is being on the romosozumab for 1 year, sequential therapy with the oral injectable anti-resorptive agent. If patient is on abalopartide or teriparatide for up to 2 years, sequential therapy with oral injectable anti-resorptive agent. If patient is on zoledronate, if stable, continuous therapy for 6 years. If progression of bone loss or the recurrent fractures, consider switching to abalopartide, teriparatide or romosozumab. So these are the very important points For 10 years, major osteoporotic fracture risk is more than 20% and hip fracture is more than 3%. So these are the important points. And then on the role of MHT in the postmenopausal females, Endocrine Society says that the MHT should be used for the prevention of all types of fractures in postmenopausal women at higher risk of fracture and following collapse. If she is under 60 years of the age or the less than 10 years of the past menopause, those in whom biphosphonates or the denosumab are not appropriate, with bothersome vasomotor symptoms or without contraindications can be given. So use of MHT to a symptomatic women is what is window of opportunity osteoporosis. VMS and osteoporosis, any correlation? Yes. Moderate or severe VMS, lower BMD at the femoral neck and lumbar spine, increased rates of hip fracture. Osteoporosis related mortality can be reduced if MHT is initiated, both symptomatic women before the age of 60 years or within 10 years after the menopause. Our window of opportunity is initiation. The age of 60 years requires an individualized approach. So this is a pragmatic approach. Osteopenia not meeting therapeutic threshold for osteotrophic drugs, then intolerance to drug. If there is osteoporosis and refractory osteoporosis, atypical fractures, MHT should be considered. And these are the beneficial things. Individualized MHT is very important. Less than 40 years of age, MHT is mandatory. 40 to 50 years, benefits exceed risk. 50 to 60, benefit exceed risk if 10 years of menopause, and risk more than 60 years, risk can be more, need to evaluate. So baseline investigation, CBC, lipid profile, cervical smear, HPV screening, glucose, vitamin D level, transvaginal ultrasound, TSH, renal and liver function, and mammography. Now, counseling to the woman to address the concerns, questions on menopause and MHT, to educate women, enhance the confidence, and facilitate the decision making. So what counseling will include? Meaningful relationship, respecting her preferences, evaluating and understanding of women, risk explained in absolute number instead of relative risk. There should be informed decision making, clear communication. These are the important components. And benefits are of the overcomes the deficiency, improves the lipid profile. There is a high density lipoproteins and decreasing the total cholesterol and low density lipoprotein. Then reduces the risk of coronary heart disease by 24%. It improves the BNP, significantly reduces the risk factor. It reverses the urogenital atrophy causes by estrogen deprivation, relieves vasomotor symptoms, and improves the overall quality of life.